Awesome. Yeah. Thanks so much for coming. I'm super excited to talk about a topic that I've been interested in since 2015 or so, when I first came across the writings of people like David Pierce and Brian Tomasik, who really convinced me with very rigorous philosophical arguments that reducing extreme suffering should be maybe one of the top, if not perhaps the top priority of our civilization. Um, and back then I was in a relatively traditional trajectory with my career in computer science. And when I read their work, I was like, no, actually, this is what I should be working on. And back then, I was very lucky to have met a few people back in Germany who were also really convinced by these arguments. And sure enough, shortly after I finished my PhD, I joined the Center on Long-Term Risk, which is now based in London and does work basically on suffering risks from artificial intelligence. And since then, I primarily worked on risks from AI. And only recently, I decided that I wanted to work on topics more sort of directly affecting humans in extreme suffering. And the Quality Research Institute was, in my view, one of the very few organizations taking the problem of extreme suffering really seriously and thinking about it from first principles. Um, Other organizations that, I think are notable in this space are the Organization for the Prevention of Intense Suffering and the Center for Reducing Suffering. Um, and you might be wondering, like, okay, what's up with QRI focusing on extreme suffering? Because you might know them as doing consciousness research. Um, and I think there are like three, or at least three reasons why they focus on extreme suffering. One is just ethical. Um, QRI believes that studying consciousness shouldn't be done just, out of curiosity, but because the insights that we gain from studying consciousness should really benefit all sentient beings and help us find new technologies to reduce suffering and improve the well-being of everyone. And also, there's an intuition that every moment of conscious experience matters, no matter whether it's you or me who's suffering, or whether the suffering happens far away or nearby. I guess this is somewhat reminiscent of the drowning child thought experiment, but in this case, we might be talking of, say, children or people who are merely not just drowning, but perhaps experiencing extreme suffering. So I think this raises the stakes. Another reason is sort of more neuroscientific. Um, One of the core ideas that has come out of QRI is this idea of the heavy-tailed valence hypothesis, which maybe you know as the logarithmic scales of pleasure and pain, which in very simple terms is the idea that the most intense experiences, both negative and positive, are possibly like orders of magnitude more intense than mild ones. Um, and if this is the case, then this increases the urgency of reducing extreme suffering, because it might be way worse than we actually imagine. And finally, QRA has been working on these problems for a few years, and along the way, they have identified a few very pragmatic solutions that could actually make a dent in reducing extreme suffering. And yeah, we want to get the word out there. So yeah, last year I got in touch with Andres, and we started talking. We had the opportunity to meet in person in the summer. This is David Pierce as well. And he suggested that maybe I could do some research on topics that he himself had been doing previously. And in particular, he pitched me a research project. He basically said that maybe I could come up with like a table, like a quick, back of the envelope calculation of the largest sources of extreme suffering in humans today, which weirdly doesn't exist for some reason. Um, and this was at least in part inspired by an article that Brian Tomasik wrote, where he tried to basically quantify the suffering caused by different animal foods. And so we thought maybe we could come up with an analogous table, but for human suffering. And yeah, I got to work. I thought that was exciting and thought, okay, maybe I can start with cluster headaches and trying to quantify the suffering caused by cluster headaches. In part because QRI had already done some work on this problem, and in part because I thought, yeah, this could be one of the top contenders for the largest source of extreme suffering in humans. And so I want to spend a couple of minutes talking about the basics. So I'm curious, who had already heard of cluster headaches before this talk? Okay, quite a lot. In my experience, very few people have heard of cluster headache, even though the lifetime prevalence is somewhat similar to that of MS and Parkinson's. And basically, a cluster headache is a super painful attack, typically happening or felt behind one eye, one side of the face. And it's typically described as sort of like being stabbed with a knife or with a hot rod repeatedly for typically between 15 minutes and 3 hours, sometimes longer. And people who get cluster headaches report it as being by far the most painful experience they've gone through. So in this survey of 1,600 cluster headache patients, they were asked to rate the pain of their cluster headaches from 1 to 10, and the mean response was 9.7. Most of them rated the pain as 10 out of 10. And they themselves were asked to rate other really painful experiences or conditions that they had, such as labor pain, kidney stones, gunshot wounds, stab wounds, and all of them were significantly less painful than cluster headache, according to them. So they're called cluster headache because for 80 to 90% of people, patients who have cluster headaches, namely episodic patients, the attacks come in clusters lasting typically between 1 and 12 weeks. And so during this cluster, they will get attacks pretty much every day, often multiple attacks per day. And once the cluster is over, the attacks will stop entirely, and they usually come back typically the next year, sometimes more often, sometimes less often. And for a minority of chronic patients, they get these attacks all year long, sometimes just every day without any remission. So I won't describe the pain in great detail, but I'll just leave this somewhat poetic description of a cluster headache patient who describes, for example, a cluster completely violating your being and conquering your mind, your body and soul. Describes it as a cruel and terrifying ritual beyond any logic. And so basically what I wanted to answer was this question: how much time is spent globally in cluster headache pain per year? And this is actually a pretty easy formula. Basically, you just need to multiply, okay, how many people get cluster headaches in a given year, how many attacks they get per year, how long each attack is. And I was also interested in looking at the distribution of pain, because some attacks are not as intense as others. And so each of these quantities is a probability distribution. And yeah, what started out as a quick back of the envelope calculation became a much larger project of its own, which you can read here on the EA forum, and hopefully also in a peer-reviewed paper that we submitted for publication. You'll also find a link to some simulations that we created where you can play around with the parameters of the statistical model and run your own Monte Carlo simulations. So this is what we found. So here what you see is the average number of hours per year that cluster headache patients spend at different pain intensities every year. And I found it useful to distinguish between 4 different groups of patients, depending on whether they're chronic or episodic, and depending on whether they have access to treatment or not, so pain relief, basically. And as you'd expect, people who are chronic and don't have access to treatment spend the most time in pain. So here the gradation in the x-axis is 0.1, and as you can see, the average patient spends about 9 hours at 10 out of 10 pain every year. And so if we just aggregate the numbers for all cluster headache patients globally, because this is just for the average patient, we get something very similar. But in this case, the burden is dominated by the episodic patients who don't have access to treatment simply because there are many more of them. And the y-axis here is not just hours, but person years per year spent in pain. And so from this distribution, we can derive two metrics that I think are particularly helpful. Namely, now we can look at how much total time is spent at least 7 out of 10 pain, and also at least 9 out of 10 pain. We can just like add up all the time. And if we do that, we get something like this. Basically found that cluster headache patients globally in a given year spend somewhere between, well, about 47,000 person years of pain at least 7 out of 10 pain, and about 13,000 years in pain at 9 out of 10 or more intense pain. Translated to person days, that's roughly 5 million globally. In the UK, that's about 46,000 person days of pain at that level. And that also means that right now, in this instant, about 13,000 people are experiencing this type of pain from cluster headache, about 125 in the UK. We wanted to look at these two metrics because they have been suggested by Jonathan Layton from the Organization for the Prevention of Intense Suffering, who called these two numbers years lived in severe suffering and days lived in extreme suffering. And he suggested that perhaps countries, governments could try to quantify these two and keep track of them and try to minimize them. And one of the main motivations is that many of the metrics that are used in global health are somewhat insensitive, or perhaps totally insensitive, to what happens at the extremes of suffering. And so just to illustrate this with the DALY, perhaps you know the DALY is one way that we have to quantify the burden of different diseases. And the DALY is an incredible tool, and it has been instrumental in saving millions of lives and helping us allocate resources better. But sadly, it's largely insensitive to cluster headache. And to illustrate this, perhaps you recall that the DALY is calculated as the sum of, well, how many years you lose to death caused by the disease, and how many years you lose due to the disability caused by the disease. Now, in headache conditions like cluster headache or migraines, well, those don't cause any death. They don't cause death. So the first term is 0, and the years lost due to disability can be calculated roughly as basically the product of how many people have the condition, how much time they spend in pain, and then a so-called disability weight that goes from 0 to 1, where 0 means perfect health and 1 means death. So for example, you can do this for migraine. So migraine affects roughly 1 billion people. It's a major disease. And it's estimated that they spend about 10% of their whole time in pain, in migraine pain. And it has been also estimated that the disability weight is 0.44. And so migraine causes 44 million DALY every year. You can try to do something similar with cluster headache. There are the order of magnitude of 10 to the 6 people with cluster headache worldwide. The attacks are shorter. They spend much less time in pain. And there's actually no disability weight for cluster headache. The disease doesn't even appear in the Global Burden of Disease report because it just doesn't affect very many people. But even if it had a very high weight of, say, close to 1, the product would still be just, a rounding error compared to other diseases. And so just to bring this home, this has really consequences in how we allocate resources. And even though the UK government doesn't strictly use the DALY to allocate resources, for example, grants or deciding how many clinical trials to run. The fact that cluster headache is virtually an invisible condition according to most metrics means that, very little funding and attention goes into it, even compared to conditions that affect a similar number of people like MS. So it's a thought experiment to illustrate why the DALY is inadequate in thinking about this problem. Imagine that you're told that you have to undergo major surgery, but that there's no anesthesia available. So you'll be awake the whole time, and it'll be maybe a few hours of excruciating pain. And this used to happen before anesthesia was invented, obviously. But let's imagine that afterwards you're totally pain-free, and there's no risk of dying. So what is the DALY burden of this situation? So you don't die afterwards, so that term is zero. And you're also not disabled afterwards, unless, of course, maybe you develop some sort of PTSD, which can happen. But really, the burden is just those few hours of really excruciating pain. And so it would again be just a rounding error. And obviously, this is not the right way to think about this problem. And sadly, I think that's the situation that cluster headache patients find themselves in right now. I actually have reasons to believe that cluster headache pain is more intense than surgery without anesthesia. Okay, one final thing we did in our report was to compare the burden of cluster headache with that of migraine. And so we're actually not sure what the pain distribution for migraine looks like. We know that the pain can be very intense, but not nearly as intense as that of cluster headache. So here's just one example. And as you can see, the y-axis are very different for both conditions, simply because migraines affect way more people and they spend more time in pain. But one could ask, for example, what if we were to weigh more intense pain more heavily than mild pain, which, in very simple terms would mean something like multiplying these curves by some factor that maybe increases as the pain increases, perhaps exponentially or so. And if you do that, you get something like this. And, depending on how heavily you decide to weigh intense pain relative to mild pain, then the intensity adjusted burden of cluster headache could, given some assumptions, be higher than that of migraine. Of course, one could argue, it doesn't really make sense to compare or to weigh really intense pain with mild pain. An analogy that my colleague Andres has used is sort of like asking yourself how many days of light rain would make up for one day of a Category 5 hurricane. Somehow the question doesn't even make sense. You might have also noticed that the red curve sort of shoots up in this very unnatural way, unlike the migraine curve, which remains smooth. And that's because, if you recall, the plot that we had looks sort of truncated, and it is truncated at 10 out of 10. And this is an indication that there might be some sort of ceiling effect at play. Now, what do I mean by that? Basically, imagine you ask cluster headache patients to rate their pain from 1 to 10. What you will observe, and indeed what we do observe, is that a lot of responses will cluster at the very top or at the ceiling of the scale. So you'll find a lot of people giving 10 out of 10 as the answer. And this tells us that perhaps the scale that we're using or the methods that we're using are not appropriate to capture what's going on here at the extreme. To illustrate this, I found this headache diary of a cluster headache patient who, as you can see, kept track of the pain of different attacks day after day. And at some point, he rated an attack as 10 out of 10, just super intense. And the day after, he seems to have experienced an attack that was even more intense, which he rated as 11 out of 10. And it's actually pretty easy to find testimonials of people with cluster headaches saying, I thought I'd seen it all and experienced it all, but yesterday I had an attack that was, 12 out of 10, 13 out of 10. Um, this one I found just a few days ago where the person said it was literally a 14 out of 10, like uh, what's even beyond what's conceived possible. So yeah, there's definitely a lot of research to be done here, and this makes us think that actually our estimate might even underestimate some of the burden of what's happening at the tail. Now, admittedly, cluster headache is a relatively rare condition, and so if you ask just the average person, what's the most painful thing you've ever experienced, one of the most common answers is actually kidney stones. Um, Kidney stones affect about 10 to 15% of people in developed countries. In some countries that are maybe warmer or more dry, it can be as high as 25%. And yeah, people describe the pain as, so extreme, it is almost like a living thing. Or in this case, this person said, 10 out of 10 pain for almost 8 hours, or 12 out of 10 pain for hours. It is really excruciatingly painful stuff. And so you might be wondering, okay, what can I do to avoid this? This sounds terrible, and it is. And if you go online and just search, how to prevent kidney stones, by and large, you'll find mostly lifestyle interventions. Um, in particular, drink more water and minimize your consumption of high oxalate foods. Now, I personally didn't know what high oxalate foods are. I'm not sure if you do, but in any case, it seems like this strategy is not really working because the incidence of kidney stones has actually been increasing steadily in recent decades. And so when my colleague Andres was looking at this problem, he noticed that a lot of people online in places like Reddit or um, Facebook support groups, there were a lot of people reporting like exceptionally good results from using a supplement, basically a herb called Chanca Piedra, which basically means stone breaker in Spanish. And it's a herb native to Central and South America that's been used for centuries to treat kidney stones. And the testimonials that people were sharing were like, yeah, really, really impressive. These were often folks who had had kidney stones for many years, who gave very detailed descriptions of their condition, who seemingly didn't have any financial incentives to be, pushing this supplement. They were not advertising any brands, and there were a lot of them. And interestingly, you won't find this supplement mentioned in most official guidelines or other official looking websites. Um, so what's going on there? We're not sure. It seems like there hasn't been a large scale RCT on Chanca Piedra. There were a couple of them, pretty small, done over 20 years ago. And so this is not really recommended yet by anyone, but it seemed like there was a signal here. And we were wondering, like, if there is a signal here, is there a way to extract it? Because obviously, online testimonials and product reviews are generally not um, valuable or like valid scientific data. Um, and so we decided to follow this strategy. So first, we compared reviews and testimonials of Chanca Piedra across 3 different platforms. Namely, we looked at WebMD reviews. We looked at Amazon product reviews of different brands and Reddit posts and comments. We scraped many of them and classified them along dozens of criteria. But then we also did the same for other treatments for kidney stones, both official recommendations, but also remedies that people typically use on those same platforms. Then we also looked at other supplements that people already take all the time, such as ashwagandha and melatonin, just as a sanity check. We also looked at subsets of the data, of the testimonials and reviews. And for example, we looked at only the most credible ones, or only those written by people who reported having had kidney stones for many years, and so on. We made sure to look very closely at any severe side effects that people reported from using this supplement. And we also took a deep dive into the literature of Chanca Piedra and just read anything we could find to see if we could explain the effects in a more sort of mechanistic way. So this is an example of what we found on WebMD. So here you can see 5 different medications, treatments that are used for kidney stones, and the number of reviews we scraped and analyzed. And as you can see, a very high percentage of people reported Chanca Piedra helping with kidney stones in one way or another, especially compared to the other products. And also notable is that very few reviewers mentioned any negative side effects. So WebMD has a database of roughly 1,300 vitamins and supplements. And so we thought, why not just scrape them all and look at the overall rating that these vitamins and supplements have. And when we did that and ranked them, what we found was that for products that have at least 50 reviews, Chanca Piedra was number 5. And for products with at least 100 reviews, Chanca Piedra was the second highest rated vitamin or supplement on WebMD. The results on Amazon were maybe slightly less impressive, but still very promising. We scraped product reviews from, I believe, 9 different brands, and also looked at other kidney stone products. And here again, people reported it helping, maybe not as much as others, but still comparable, and with, again, very few side effects. Finally, on Reddit, we scraped all the posts and comments on our kidney stones that mentioned any of these 9 treatments for kidney stones. And here you can see the number of reviews and of posts and comments that we scraped. And here again, Chanca Piedra was apparently, as effective as other treatments, if not more effective, with extremely few reported side effects. Here finally you can see the percentage of total reviews that mentioned any side effects. This is for all the testimonials, reviews, and so on that we analyzed from all platforms and for all of the products that we looked at. And as you can see, still Chanca Piedra has apparently very few side effects, which is striking, especially compared to things like ashwagandha and melatonin, which people already take all the time. Perhaps you do. So our overall take is that this seems to be a potentially really promising intervention to especially prevent kidney stones from even developing in the first place. Obviously, there should be a large RCT, but in the meantime, this could potentially help a lot of people. You can check out our results in this post. There's also a link to a dashboard with all the statistics that we analyzed if you're curious. Okay, so just to wrap up, if you're curious about what can be done about the problems that I talked about today, I invite you to check out our posts. We have sections there with recommendations. If you're wondering what you can do specifically, I think donating, if you can, is an excellent way. I think, or if you know someone who can provide funding for this type of work, there is not much funding in this space, and there really are just a handful of us working on these problems. You can follow QRI on social media, sign up for the newsletter, shoot me an email if you want to get involved, collaborate somehow. Some of the things that we're working on at the moment or plan to work on include open letters advocating for access to psychedelics for cluster headache patients, because a large fraction of cluster headache patients report immediate and often permanent relief from cluster headaches um, from using things like psilocybin, LSD, and DMT in even very, very low doses. But obviously, these are still illegal in most countries. We're also working on a tool to visualize tactile sensations, including pain. Um, we're thinking also about doing cost effectiveness analyses of various interventions and organizations working on cluster headache. We're collaborating with others, for example, at Opus, to map the global burden of extreme pain, which I never got around to doing in the end. And with funding, we would love to run a research fellowship or a conference on these topics. Yeah, that's all I have for now. So thank you so much. I believe there's a Q&A later, but not now.
Let's do a few now and then later this way.
Sure. Yeah.
So my question is about the kind of mechanism of action, or maybe what is the general difference between cluster headaches and migraines? Is there some difference in the mechanism of action and maybe also the indication, or maybe the therapeutics that are offered for these two conditions?
Yes.
Or is it just, like you pointed out on one of your slides, a difference in severity?
Yeah, it's a pretty different condition, and the fact that it's called headache is a bit unfortunate because people tend to lump it together with other headache conditions. Um, it has a sort of circadian and seasonal aspect to it, which means that certain parts of the brain are involved that are not involved, for example, in migraine, because the attacks come usually at predictable times of the day and at predictable times of the year for many patients. And yeah, the severity is just way way worse. So much so that patients with migraine, for example, they try not to move. Often try to avoid lights, want to just be left alone. Whereas the pain of cluster headache is so severe that people have to scream, yell, sometimes hit themselves on the head so that they can feel any relief from the pain. So yeah, they're quite different, and the things that work for migraine don't work at all for cluster headache, sadly. Yeah.
A follow-up on that then, just I'm interested in comparing, you mentioned that the access to funding and regulatory framework is limited because a lot of systems use DALY. If you considered the quality system, then you could make the argument that it doesn't so much depend on the prevalence as it depends on the impact.
Yeah.
Because there are rare diseases that are reimbursed under the quality system, and a lot of countries do implement it. So where really is the bottleneck? Like, is it hard to prove the detriment that these cluster headaches cause?
Yeah. Actually, I've talked to someone who also suggested that perhaps the quality could capture some of what's happening here. As far as I know, it's not really being done. Um, in talking to others who are advocating for pain relief for cluster headache, or generally more awareness for cluster headache, the bottleneck seems to be just awareness. Like, people just have never heard of cluster headache. They think it's not as bad. And even in the UK, patients have a really, really difficult time getting first the diagnosis, and second, a prescription for something like high flow oxygen, which helps a lot of patients. It's still extremely hard for patients to get access to treatment. Yeah. Yeah.
Yeah, fantastic talk. Thanks away. Thank you so much. Really interesting stuff. The answer is probably in some way on this slide here, but I suppose my question is just off of the back of that. I mean, what are your sort of both personal and kind of researched feelings toward how do we get I guess negative, like, utilitarianism generally, but specifically how do we get tackling extreme pain as an issue to be something more widespread, more funded, more in public consciousness, rather than just the people that get it, the people that suffer from it. pushing for these things,
Yeah. Great question. I'm honestly not sure. I think things like potentially the uh, tactile visualizing tool could help like really I mean, we're hoping that maybe we could find a way to really visualize the pain of cluster headache so that it's maybe more um more vivid and people actually understand it better. um there also seems to be uh some momentum around, for example, psychedelic access to um anyone who is suffering with, say, pain or um, mental health conditions. So it seems like the tide is turning and more people are taking these problems seriously. Um, Honestly, I'm not sure. I think, some of these ideas have been around for years, and, some of us are, trying to build a community around this. I'm not sure at this point what could help other than there being, uh, influential people, politicians, billionaires who take this seriously and decide, this has got to end, and then perhaps, then perhaps public opinion will follow. Perhaps we also develop new technologies that immediately and easily get rid of extreme pain, and then it won't even be a matter of debate or anything. It'll just be hopefully so easy to get rid of the pain that everyone would just have access to it. So that's also one hope, just developing new technology.
Yeah, or we try and get like Andreas and David Pierce on something as evil but influential, Joe Rogan host.
That would be great. If you have any connections, let us know.
Good try.
Uh,
Actually, meant they do. Oh, it's up to you.
all right, yeah, great. Maybe you, yeah.
Thanks for your talks. I was just curious if you are you aware though that there were some that there are some substances that were discovered that do not at least cause the same sort of visual hallucination as normal psychedelics do, but also still seem to work on the 5-HTP receptors and reduce depression and such. Do you think those ones would affect cluster headaches as well? And maybe would it be easier to distribute those?
Possibly. We haven't looked into it in detail, but I think it's likely. Um, yeah, and if that's the case, then perhaps that's an easier entry point into making these substances available to cluster headache patients. Of course, you never know if at some point the authorities then decide to add these substances retroactively to Schedule 1 or so, but it would definitely be worth exploring. I think it's quite likely that they would have some positive effect. Yeah. Salvius, yeah.
Any idea though if non-human animals might also be experiencing cluster headaches?
Not that we're aware of. But I was actually discussing this with Andres, and we searched for a few minutes and didn't find anything. But if that's the case, it would be great to know. I do think that kidney stones are common in animals. So yeah, there's also some work to do there. We wanted to include a section on animals with kidney stones in our post, but it was a bit out of scope. Yeah. Okay, maybe a couple more. Yeah.
You talked about the limitations on comparing extreme pain to lower levels of pain. If you had huge amounts of funding, what methodology would you take to try and get a robust way of having meaningful comparisons to be able to compare the total burden of mild headaches globally to the total burden of cluster?
Yes. I think I would personally try to treat them separately using the metrics that I mentioned, like the days lived in extreme suffering. And I would honestly prioritize those over, say, pain of mild headaches. However, as we also mentioned in our post, the fact that cluster headaches don't affect a large number of people means that maybe actually we don't need to make like huge investments to just get rid of the problem for good. So this is perhaps an opportunity for a philanthropist who's like I'm willing to pay this much money, and the a few million people worldwide who are getting cluster headaches should have access to these substances or oxygen, and and it wouldn't necessarily require global coordination or like governments reprioritizing their approaches. Yeah.
I mean, would someone who experiences cluster headaches, for instance, say, I would rather have not one more cluster headache, like if either a choice between one more cluster headache or the rest of their life, let's say 50 more years with a constant mild headache.
Yeah.
Would they say in that instance, I'd rather have 50 years of constant mild headache than no cluster headache? For the thing I'm still not getting the equivalence, and maybe it's what you were saying about the difference between constant light rain and a hurricane. But it seems to me that it'd be very, very powerful to be able to have a quite robust way of having this all quantifying the same framework.
Yeah, actually, Salius here was doing a survey where he was trying to ask people about those trade-offs. I think it would be, extremely valuable work. And as far as I know, there's almost no research on this question. I think it would be interesting to know, and perhaps we should make those trade-offs. I'm not sure what a cluster headache patient would respond to that specific trade-off, but also, there's some interesting philosophical questions related to personal identity and how we conceptualize specific moments of experience and how they're distributed across different individuals that complicate these questions too. So I personally care about there generally not being any cluster headaches, even if they don't happen to me. But I think definitely, this is still like an incredibly understudied question that I don't know. I just hope that that this changes very soon. Okay, maybe last question. Thank you.
I was going to ask, related to that, I've seen some proposals around extending the range of waiting for a DALY or boy beyond 0 what. Have you done that at all? Would that changing it up?
I haven't looked into it. This is the first time I hear about it. So that'll be interesting for sure. So yeah. Thanks. Cool. Thank you. Yeah, thanks.